Thank you for the opportunity of presenting. I have no disclosures. It has been established and widely accepted that the endoscopic resection of neoplastic colonic polyps may be curative. And this endoscopic resection may be curative depending on the histological features of the polyps, the depth of invasion according to the Kikuchi and the Haggis classification, and also according to the presence of polypectomy margins free of disease. There is a concept of interval colorectal cancer, and the related factors that have been studied to this are the low-quality colonoscopies, the missed polyps, some genetic factors, and the concept of incomplete polypectomies. This last factor carries us to the concept of residual neoplastic tissue on the polypectomy site. On the other hand, we have to face some difficulties in our daily practice related to some pathological issues, such as the precise measure of the submucosal invasion, and when we face to a pathological reports that says indeterminate resection margins. Moreover, there is the information regarding the prevalence of RNT after polypectomy in the literature is limited. Thus, the aims of our study were to determine the prevalence of RNT in surgical specimens from patients undergoing colectomy after endoscopic resection of malignant colon polyps, and to evaluate the relationship between RNT status and the type of polypectomy, the resection margins, and the depth of invasion. We performed an observational retrospective analysis using a prospective database. So from 2003 to 2011, all patients with colonic neoplastic polyps treated by laparoscopic colectomy were prospectively recruited. We included those patients with polyps containing in situ or invasive carcinoma, and in whom an endoscopic polypectomy with curative intention was performed before surgery. We analyzed these variables, demographic data, polyps morphology according to the Paris classification, the type of polypectomy, and the histology. The polyp resection margins informed by the pathologist were classified into three groups: complete, incomplete, and indeterminate. And this last concept was mostly because of thermal injury, polyp fragmentation, or orientation difficulties. The primary outcome measure was the proportion of patients with RNT in the surgical specimen, and as secondary outcomes, we measured the relationship of RNT with the type of polypectomy, the depth of invasion, and the resection margins informed by the pathologist. The results were expressed in percentage, and the proportions were compared using the chi-square test. So from the previous mentioned period, we performed 780 laparoscopic colorectal resections. 90 of these procedures were due to colorectal polyps, and in 46 patients with previous endoscopic resection with curative intention, and this is a sample of our study. The mean age was 63 years old, 55% were male, and the main indication for colonoscopy was screening, followed by bleeding and abdominal pain. Most of the surgical indications were due to submucosal invasion, incomplete polypectomy, or endoscopic mucosal resection persistence or recurrence. The mean size of the polyps were 1.8 centimeters, and the most frequent location was the sigmoid colon, followed by the right colon and the rectum. The morphology, or the most frequent morphology of the polyps, were the 01S, that is to say the sessile polyps, followed by the pedunculated and the flat elevated. And the histology of the polyps in 34 patients were carcinoma in situ, and in 12 adenocarcinoma. The histology of the adenomas were the most frequent tubulobilious. Looking at the primary outcome, we find that the overall prevalence of RNT in our sample was 56% of the patients. And when analyzing the secondary outcomes, the relationship between RNT and the prevalence according to a type of polypectomy, we found that when a forced polypectomy or when an EMR polypectomy were done, a high percentage of of patients had RNT, and this was statistically different between the patients of these two groups and the snare polypectomy patients. We also found that the RNT prevalence was 0% when the pathologist informed us a complete resection, and was similar RNT prevalence with the incomplete and indeterminate resections. And the incomplete, there was a statistical significant difference between the complete and the incomplete resections, the percentage of RNT in these both groups. Finally, the RNT prevalence and the depth of invasion, we have found similar RNT prevalence in polyps with in situ carcinoma and adenocarcinoma. A couple of limitations of our study is the retrospective analysis, and we have, I'm sorry. Can I have the, and there was, we didn't have a second evaluation of a second pathology. Thank you very much.
Okay. I'm not sure what you're trying to prove with your presentation. It's interesting, but for it to be meaningful, you must separate polyps from invasive cancers and pedunculated cancers. What you're trying to do is to build the case for decision-making. And I don't know how we can translate your information to better decision-making. Perhaps you can tell me. Factors such as the technique of removal. It's obvious that if the cancer is sessile and large, the snare will not be used, it will be forceps. So that makes sense. In any case, I think your paper can be paired with the University of Nice paper, and perhaps help can be directed towards our decision-making. Thank you.
Okay.
Are there any questions from the audience?
Was there a question in that?
I forget.
We are pointing to what is happening in real life. So we know that concepts, and we think that we have to take care in perhaps a misinterpretation of some small polyps that are taken with forceps. That's why we have a high prevalence of residual neoplastic tissue in the forceps polypectomy. That's why we think that it's important to analyze, for example, the pit patterns, or to use the NBI technology so as to have a better interpretation, not only in the size of the polyp, but to see the pit pattern so as to select a correct way of taking out the polyp.
Are you doing the polypectomies, or this referred?
No, we are doing the polypectomies.
What? Yeah, last question.
It has to be brief, Emmanuel.
Yes. Indeed, we see in the clinical practice more and more cases that has been performed by endoscopists with the submucosal share with the electric power. This is a really clinical problem, because SM criteria is very important to evaluate the risk of lymph node.
Is there a question for him?
The question is, I think that the society should give more prizes, guideline on which polyp should be removed by endoscopists and which not. There's still too much confusion. Just a comment.
No question.
I agree
Okay,
with
thank you very much.
Okay, thank you.
Thank you.